Hi Vijay, hi Marcia. How are you?
Hello.
Hello. Great to see you. Hi Vijay, great to see you. How are you?
Yeah,
Oh, by the way,
been on holiday. Yeah, so
quick question, Vijay. We are recording it. Is it okay, or
yeah,
do we have
fine.
to? That's
Yeah,
fine.
it's okay.
Yeah, it's all right. So I've been on holiday, so I've missed a few meetings.
Yeah, I was wondering what's happening. Why is not Vijay responding to the calls? Now I know.
I've been in Copenhagen and I had some meetings and stuff. I got back today actually. It's been about 12 days. How are you?
Good.
Hi everyone.
Good. Hi.
Yeah, good evening.
How's it going, Clever?
All right. Oh, Massa.
Hi, Clever.
Clever, are you from Argentina or are you from Brazil?
From Brazil, yeah, Recife.
Okay, okay. I'm not going to bring up the Copa America.
Yes, please. But I like Messi, so I'm not that sad. Yeah, Messi, he deserves to get a championship, but it was good in the sense. Yeah.
Sure. Vijay, did you watch yesterday's UEFA Cup final?
Yeah, I did.
Got a heartbreak.
Yes, I did.
Yeah.
Italy, yeah.
Oh, so.
Me no, because I don't like football. I don't like soccer games.
Yeah.
It's a great
match. My father has watched. My father, but me, no.
Yeah, you don't watch.
I only hear his scream so much because of the game.
Yeah.
I think Italy played better. Yeah. But England was so close. They were such a high expectation to get a first.
Yeah. But also quite a young team too. So
yes,
they did well. Yeah. Vijay, did you watch?
Yeah, I did watch all of it, and it was nail biting,
wasn't it? Yeah. I'm pretty sure
it was good. The teams were good. I think they both played okay. Italy was obviously a bit better, and yeah. But there you go. It's football. Somebody's got to win.
Yeah, quite a
and
few.
The English goalkeeper, he had such a vibe, such an attitude. I thought he was going to catch all the balls. He was very confident, but
yeah.
The other giants.
They are, isn't it? Yeah. All right. Are we waiting for a few more people? No, but we might as well just get started. Thanks a million for turning up this morning. Morning for us in New Zealand, but definitely evening for y'all, isn't it? What time is it for you, Marcia, Vijay, and...
Here, 7 p.m.
7
Here, 7 p.m.
Okay.
Me too.
Okay.
It's 11 p.m. here.
Wow. It's quite evening for you on Monday, isn't it?
Yeah.
Yeah.
Yes.
It's 10 a.m. for us on a Tuesday in New Zealand.
What time is it there?
It's 10 a.m. Tuesday.
10 a.m. Okay.
Yeah. Oh, well, so let's get started. And were you there the last couple of meetings that we had? Okay, so let me fill you in on a little bit. We had a first meeting on July 5th and 6th. And the first one was presided or chaired by Sriram. And they were discussing the guidelines and quite a few things, what we want to do going forward, what papers we wanted to work on, a research agenda, and things like that. Those were the ones that they were discussing. I'll just share the meeting notes that we had last time, and that's in here, just in case everyone's on the same board. And so if you go there, if you click on that link that I've shared on the chat box, you'll be able to go to the page. And what we were discussing last week was about a few things. For example, what are we going to do from the follow-up to the COVID response document that we had already written for the IMIA yearbook? the guidelines and standards, which was the work that was being done by Alan Taylor and his colleagues in trying to find out what some of the best practices in terms of telehealth, things like that. And going forward as to what our thoughts about the MedInfo. As you know, MedInfo is happening this year entirely online, I think free of charge. So if we could do something to show up and present our work, or unfortunately the abstract submission deadline has passed. But nevertheless, if there are working groups and things like that that we can be part of, it'd be really nice to go and see what we can do this. Certainly for next year's yearbook, journal time will be up pretty soon. And what are the works? What are your thoughts, basically? So it's more of a, at the moment, it's kind of finding out what we are thinking. So now over to you all. This week, we don't really have any agenda. I was hoping people would write some agenda items, but that's fine. We certainly can have our own free-wheeling discussions and see what are we thinking.
Yeah. Well, my interest is looking at how, because I'm doing this, I'm commissioning as well as GP and all the rest of it. Mm-hmm. I just joined NICE as a fellow.
Yeah.
I'm just looking at quality numbers. So the main thing I'm looking at is they're going to use a lot of AI now in terms of getting information rapidly to the front line, but have easy access. So although they're really good guidelines, it's about making them, it's into practice use. So how to get theory into practice, which is obviously a big one for a lot of people. Even with telehealth, you have lots of guidelines or proposals. If nobody uses it, it may, translating it, if it's not translated, it's not used, it can be a big problem, as we've heard in various things we've done with the various papers. So my interest is really the long-term conditions, how we can make best use of it, not only with COVID, but the backlog of care, which is going to hit us for a few years. And I think people are going to need something which will accelerate self-care, self-management, supporting the front line, just families. So it is a kind of an urgent need. So if we're going to do anything which had impact, it will impact globally. So that's my view. If we do anything, it's got to impact what's needed now. I think healthcare systems are going to struggle with the demand, and people have been saving up their problems. Fear of entering, getting the potential risk of getting the virus is still there, although it's less with the 2 vaccines. And so we can do it remotely better, but also be able to know when to escalate into face-to-face. That's kind of what I'm looking at the moment in the delivery, because we're getting work streams based on those systems. But obviously, also we're then doing the multiple long-term conditions. So then there's comorbidities, frailty. It's a huge one, because it's potentially a bit of a struggle because services aren't all up to speed, but the clinicians are there. So it's causing barriers. So that's where I'm coming from. And if we're working on anything, the list you've got on the discussion thing is good because it covers the things. But if we're looking at theory, then I think it's definitely good because that's what we want. We want the basis for guidelines and what to follow. Standard.
Exactly.
But if we look into practice, it's a different thing. It's a different emphasis. And I think it's very hard to mix the two up because they both require a lot of work in what we do in terms of papers or sharing experiences.
Exactly. And that has been a thank you for bringing it up, Vijay. That was a theme that we discussed in terms of translational issues. So we have guidelines on one side, but we are actually people with boots on the ground. And then how do we bring the parity between all of those theory-driven guidelines and best practices and things like that, but how do we translate that is what I'm also hearing you're bringing in that perspective, isn't it? And that I think will become, and oh, there is Alan. So we had the discussion. Hi, Alan, are you there? Just a man that we were thinking of.
So did you solve the problem?
And that I think is kind of the holy grail, if I can use that term. But yes, indeed. I mean that we talked about that. We discussed that last week in terms of how do we negotiate that space of translational care. On the one hand, we have the guidelines, we have the theory, we have the best practices. On the other hand, there are people that are implementing them. What's the implementation science for the translational work?
Yes, I didn't watch the video, but as I hear in the video, I want to know more about Alan, because I didn't have access to the ISO
13131.
Yeah. And I didn't set how kind of standard are you talking about? And I don't know if you can use all of this in all of the countries that you have in all of the world. So I want to know more about this ISO, this standard.
Probably, Alan, if you can kindly enlighten us. Are you there?
Alan, you are mute if you are want to
Hi, Alan.
talk.
Can you please unmute yourself and let us know? Are you there? I can't see Alan there. Yeah, I can barely see Alan. There's a shadow out there. Yeah. Yeah, I think that's a good question. And I think the best person to answer that would be Alan Taylor when he comes on and when he takes on the mic. Yes. So that could set the theme for us as to what standards and what are being expected. So.
Because in some time of the video, I heard a little about the consumer health, and I am very I want to know about that because my research line is patient engagement and consumer health informatics. So I want to know what we have to talk about with these two kind of things, the standards and if they are relation or not with the consumer health, because I didn't understand so much what you are talking about in the last meeting.
So Marcia, if you can kindly let us know about your line of work and what you were thinking about in terms of consumer health and what exactly do you do? And Clever also, if you can kindly add to that. And so Marcia, over to you.
Can you repeat, please?
Marcia, you said that your area of work and your area of interest and specialization is on consumer health and bringing informatics into it. So if you can kindly elaborate that a little bit.
Because I talked about telehealth, the consumer health, because you want to know how the consumer health informatics can more use the telehealth, how they use this. So a method to metric to count the engagement, it is important. And for this, we can write some standards to bring these people to more engagement, the telehealth system. So this is my proposal, to study more kind forms of evaluation, the engagement of the people for the telehealth system.
So,
and I think this is a relation with standards, because we have some kind of problems with the health literacy. So some standards to how to develop this telehealth for the some kind of people that don't know words in health or something like that. It's important. I think so.
So when you mention the word consumers, what class of what class or what groups of people do you have in mind? Are the technology, the patients?
Yeah, the patients, because if you, I know that there was. I tried to keep together with the working group of consumer health. I tried very much, but I didn't remember the name of the coordinator. They didn't answer my my emails. So I decided to do something different, and I get together with the telehealth working group.
Mm-hmm.
Because I see that there is so much relation with the patient to use the telehealth system. And if you read the book about consumer health, the consumer health informatics is the someone that use the telehealth system or use the system health. It's not the doctor, not the health professional, but the people, the care, the care manager, the care patient, the patient, and they are the consumer health.
So which means the non-clinical staff that have been driving the usage and utilization of the healthcare system, isn't it?
Yes.
Yeah. And that's been a thing that we've been discussing last week as well, in terms of the last mile problem in connecting and using this. And there's the same thing that Vijay, you were raising, you just talked about now, in terms of, okay, we have all of these efforts in terms of the systems, and we have got the backlogs connecting people. Yeah.
Yes. My PhD study is about a model that connects the professional, the health professional, to his patient. And I see that a big problem is not the health professional sometimes. It's the patient, the patient care, that they don't know how to talk, or they didn't understand what the professionals are saying, and the information that we have that they have to read sometimes is difficult for him or her to understand. And this is the line, my line research that I decided to study more.
I think the theme that we are heading towards, particularly this week, is very interesting, is that translational issues in its many dimensions, isn't it? So there is the implementation science of it, the translation of this, right? I often think that the patients and the consumers are privy to certain information that we as clinicians and as doctors and nurses and deliverers of the service may not know, and that's their information. Yeah. And we have information, we have the content, and we have the knowledge and the processes that they may not fully understand. And
yes,
but
I think that we can use the machine learning or artificial intelligence to understand more the patient, and to support the professional to understand more their patients. So the professional can do more for them, and saying things that they understand, or they have to use or to do.
Exactly. And without that, the machine learning algorithms may start I don't know what's going to be the, none of us know. Probably, I mean, this is another area where we can probably start thinking in terms of how we can use our telehealth working group to see and sync with the AI and things that, how what role will that play with telehealth? There was a talk of, I think last week about that can AI in medicine be the next Nobel Prize winner? But
I think AI can help support so much the professional and even the patient.
Yeah.
I think there's a kind of problem with guidelines, because they're usually population based.
Yep.
And we're dealing with people, as you say, Marcia, the individual, their preferences, their values, it varies. So there is a problem in kind of translating guidelines into practice. You have to personalize, and this will break down if you try and apply something which is supposed to work, which will not work for the person who may not have a smartphone, who may have one, doesn't know how to use it, knows how to use it, but doesn't know how to go on the app. The app doesn't know how to look at it because doesn't find it easy. Everybody's got different skill sets and values, and we're just different, and we have to accept it and not try and fit them to the IT, but make sure the IT personalized. That we have to move much more that way now, because people are going to have to access this stuff, and it's got to adapt to them, not the other way around. And I think we've so far been doing the other way around. It's not going to work. We're hitting mass scale now, and we haven't got time to get people to train people to use apps and stuff. So that's where I'm coming from with what I'm doing. We've got to make it useful at the point of use, and we've got to identify what people's the points that they are in IT, and then also the organizations, the systems, they vary very, very individualized how connected they are. So if we're going to have guidelines, I think what I'm trying to ask is, what are we trying to do with the group? Because to generalize, we're going to talk generally. It'll be nice and it might be some help, but if we want to deliver something to nations, it might be one thing that we look at, which provides learning, which people can then translate into their own individual needs rather than fit it into everybody's global picture. So yeah, for me, my interest is what will work, what is based on guidelines, based on national good practice, but also to be used practically. So, and that can be done quite simply. Even a product that's already out there, which is good, we can show why it's good. Why does it work? And does it actually work for everybody? Or is it just that one study who had funding and who had very enthusiastic champions? So I think our last paper is quite good with the COVID and everything. It talked about what the different countries had to offer in general terms. So that's the kind of, I think, interest for me, and I'm sure all of us actually. And that is translation, not just in guidelines to practice, but more than that, it's about real world.
So real world applications or real world experiences that we can probably start collating in terms of how we are using the guidelines to apply to specific situations. That's something that we're hinting at.
I'd be more interested in knowing, we've got a person who are trying to manage with something, and how do the guidelines make that better?
I see. Okay.
So in some respects, if it's working with that person, it'll work with other people in all countries, because we've got this guideline. You use an example, maybe India, maybe wherever, and then you say this work. That's how it worked for that person. That's how it helped the organization.
Yeah. Or
a group of people with certain conditions. It could be that way around. But going from the guideline downwards, I think it'd be very tricky. Yes. Who is the we're here to serve the population. That's what we're here for. The population needs help. We're not here to serve ourselves. We're not here to make the IT better. it's got to work. So yeah, that's kind of.
I mean, this was a thing that Kendall, Ho, and Alan was discussing. I mean, Alan, of course, we lost him because of the connectivity or whatever that happened. But Kendall and Alan were discussing this last week when they were saying that, look, you know, let's see some things that emerge out of the population practice as to do that. I hear you saying pretty much the same thing. I'll say that, all right, okay, I'm doing work, and how are the guidelines kind of being, are the guidelines guiding me to do this?
Yeah.
Yeah? How is it syncing with my practice? Kleber, you have been very patiently hearing us saying this. What would be your thoughts on this?
A few years ago, I had a discussion of a colleague, and was about the difference between guidelines and protocols. And it's at that point in time, it made sense to me. Up to there, it was like the same thing. I thought, okay, guidelines. So a bunch of experts get together, review the literature, and say, we need to do this or that. And then he told me, no, that's the guideline. It's a general rule or general pathway that people should follow. When you're talking about protocols, you take a guideline and you translate into your practice. Let's say in your hospital, you just have this specific drug. So you put this drug in the protocol for your hospital. You just have access to this particular exam. So the guidelines will make a general assumption that something should be done, and a protocol would be more specific to your environment. And that helped me a lot to understand the difference between the two concepts. And I don't know if it's what we're talking about here is something in between, how to make the guidelines be applied in real practice would be maybe show them how to make protocols or how to bring this to your own reality. So a method that they will read the guideline, but they could speed up the process of applying that to their environment. And I don't know, that was how I understood the discussion.
But in this kind of thing that I want to know, because if you are saying about the standard of the infrastructure of the how kind of a language you use or platform for this, the guideline is more specific. But if you are talking, as Kleber said, about the protocols, how someone have to use the telehealth system, how is the teleconsulting? So I think there's a guideline that maybe you have to translate it to a protocol in the hospital, in the specific hospital. Because of this, I want to know how kind of standard we are talking about. If you are talking about interoperability, it's another thing of standard. This is a standard that we are talking about IT, the language we are using, how you are using it. So we are having a guideline, but it's a more hard guideline. Our rules, they are generic, but they are specific because we are talking about a language, IT language. But if you are talking about how to use the telehealth, we are talking about another kind of protocol, another kind of guideline that I think this the same as Kleber said, we have to adapt it to a protocol where you use it.
Mm. Mm. Yes, that adds to the other dimensionality of this, because classically, when you start putting together the guidelines and standards, those are derived from the evidence-based understanding in terms of what works. But what we have been discussing here for the last week, this week, very, very, very strongly, thank you, Vijay, Marcia, and Kleber, that all right, now we have the guidelines, now we have the things that are general. How do we use that to fit and suit to the specific context in which we are working. And each of us have got a different kinds of understanding and context in which these things work. So you can't say that one size fits all, but what is my local need? What is my local context to which we are going to work with this? So what are your thoughts in how would you like to see going forward with this?
I know that there is a line research in science, in computer science, that we are using how to understand and knowledge about the process that we are using. Mm-hmm. So they are saying about process mining. It's something that I start to study because I study the patient trajectory, the care pathway, something like that.
Yeah.
And we are talking about process mining. I have some researchers, Caldamoro, and I think you know Caldamoro. Caldamoro is one of the researchers that are studying, are researcher in process mining. I think we can know about how to use the guideline, or if they are using the guideline and studying this process, going to the hospital or some where they are using the guideline and comparing how they are using the process mine. You can find it and compare with the guideline. There's a lot of studies that they are doing with protocols that I know.
So Marcia, I mean, are there specific process mining, issues and process mining's kind of documentation that you can share with the group? I think this is a great idea that can help to do this, because particularly with what Vijay was alluding earlier in terms of the use of machine learning and AI and translational issues that we've been talking about in the group. Process mining literature on that is quite useful, and possibly with our telehealth working group, if we could use some of those things, that'd be really useful, isn't it?
I have some papers. It's not with me. It's with my student. She's doing a literature review about process mining in patient trajectory, and she said to me some of this kind of research that she read in the paper.
Lovely. Yeah, that sounds like something that we could really think of, expanding on and discuss and take it forward a little bit in our group discussions as well. What do you think, guys?
Yeah, I think it's really good, actually. Really good. I'm wondering if it needs to be broken down so that you'll be looking at certain areas which will all link in. So if you're looking at process mining or machine learning AI, how does it all fit in? Because if it's going to be like a lot of different things, I mean, you could just read a textbook and get all of it out. It's like, but it's again, as a group, what are we trying to do? So if we're looking at process mining or AI or machine learning, or it's what are we planning to do with that information? Is it going to be just like a textbook, or is it going to be? So I think it's really good. I think it'd be good for me. It would be good to know what for each of the sections, what is the aim? So if we're looking at process mining, for that as a group, what are we doing for that? I think they're all good. I don't think you can actually do it all together. I think it's really, really hard. Because for me, I'm looking at a national strategy, digital strategy, which we've got people in high-level IT working out all the stuff for us, the informatics side, to make sure we've got a national glue. Then we've got a local digital roadmap, which we all got trying to work towards something. There's digital maturity. We're trying to, so we have equity across geographical areas that people are brought up to. So we're all doing this. And then there's a personalization, which Marcus was talking about making sure it means something to the people. So we've got all that stuff. It's just, when we're looking at stuff, I think each of these things you just spoken about just now would all help an understanding of where it might fit into making that work. So that part I do like, actually. So you could do it from different angles. But I think if we're going to talk about one thing, I think we should know how it fits into the ultimate goal of the pathway or the guideline. And I say the protocol. I use guidelines because they can be, they use your judgment. With protocols, you kind of have to follow it.
Yeah.
And that's how I look at it. And Clever, I think that's kind of what you said. It's very important which one you use, that in terms of terminology. And you're right, it does help. And even guidelines there put scope to it. What are the guidelines? I think what we do sometimes is say, we've got all these guidelines, very detailed, but it's up to clinical judgment at the end of the day.
Yes.
So yeah, and same, there's always going to be some scope to any guideline, even the telehealth guidelines. You know, you can't say this is it. You got to say, but it is up to the end. So yeah, there has to be scope. But yeah, no, I think it all sounds fascinating. But if we're an IMIA group, then all of it's going to be important to the group. So the context is the only thing I'm looking at, and then hopefully we can look at what evidence we can draw from various countries, what papers we might decide to might inform, provide learning. That would be.
Yeah, and certainly, I mean,
add to that discussion, and one of the, in talking about the topics and what to focus, I believe in at least in my environment here. One of the challenges or one of the threats to telehealth for me now is because we had an opportunity, window of opportunity with the COVID for telehealth. In our country, we are not allowed to do telehealth as free as we can now. So now we can make teleconsultation, remote consultations, and everybody's prescribing and doing exams, all stuff that we used to do paper-based, let's say, locally, we can do remotely. So it's a great time, very exciting for people who's engaged in telehealth. But now that COVID it's getting weaker, let's say, in our numbers, we see people coming back from the telehealth practice to the local practice. So the numbers that we have to used to have in the months ago, very high in telehealth, are starting to go down. I have an example of a hospital that we reached over 40,000 remote consultations. A hospital that did not used to do remote consultations. So after pandemic, almost 40,000, 43,000. So it's a lot, it's very exciting. But on the other hand, I see a slow decrease in the physicians' adoption, a slow decrease in some specialties. So we had this push from the COVID very strong, but I'd like to keep going. I would not like to see a few months from now or a few years from now that telehealth was just a band-aid for the COVID because they had to make it remote. But everyone went back to where they were before. And I don't think we will go back to where they were before, but I think we could keep going and speed up this process of reaching high levels of usage of telehealth. And in this sense, I have very few people really excited about telehealth. I don't think they're the majority of the clinicians. And I have adds a lot of work to work with the telehealth, and the patient has to be engaged, and the patient has to technology and be familiar with it. And sometimes they just opt to, let's go back to the traditional one. And especially for places that work with the, let's say, public health, that it doesn't matter for them if I attend 10 patients or attend 5, I receive the same amount of money. So if I offer not this kind of service would not make a difference in my payroll. And I think one of the difficulties, I don't know when it's right to perform a teleconsultation. For now, I'd say it's like a Far West, a cowboy. And now we can do whatever we want in telehealth in Brazil. But regulations are starting to move. So we have two big associations that are trying to decide if we have to or not to have a first consultation presentially, a local first consultation. Then afterwards you can do the remote consultations, or you can attend the first time the patient remotely. So this discussion is going on. So I'd like to have a pitch, and maybe an international institution like this would help if we have a few guidelines guiding when would be an appropriate opportunity to use telehealth. Not the rule, but say maybe if you're just checking follow-up exam for labs, would be fine to do over a remote consultation. Maybe if you were assessing a pain on their belly, on their abdomen, maybe it's not the appropriate. If the patient is in a critical situation and stable, maybe it's not appropriate. Some sort of guidance that people would have probably if you ask a physician, he'll know how to tell when it's appropriate or not, when they feel confident. But having a standard from some sort of community of experts in this field, maybe it would add, even for the regulatory bodies of the countries, to have this piece of document and say, oh, we're saying, okay, you can do remote consultations, but we have this piece of information here that we should guide. Yeah, just thought.
And because of this, I started a conversation last year with Alan that maybe you have must have evaluation, how to evaluate the telehealth service. Mm-hmm. I understand what you're saying about it, but if you don't know how to evaluate the telehealth, how can we supposed to write something, how to do or what to do? And I think this we have another two necessities in this kind of thing. One, the measure the engagement of the patient or the caregiver or someone that use the telehealth system as a consumer as they get the service, and the measure of the engagement of the professional, the people who use to give the service. I think we have all of this to understand more about the telehealth, and with this, I think we can write more guidelines and say if the guideline is better for Brazil or for United States or for developed country. I think we have to understand more about telehealth system. And nowadays you can do it because of the COVID. We had a lot of people using the telehealth system, not only one kind of people. You have a lot of kind of people. So I think one of the things that we can you can have efforts in this working group is maybe I suggest maybe kind of evaluate how to evaluate or measure of evaluate the telehealth system.
I think Vijay, you did some work on that, didn't it? About evaluation and process evaluation with telehealth. So let's hear from Vijay. It's a great point, Marcia.
Yeah, we looked at it was more, there's various aspects to it. It's the adoption of the telehealth. It's the scalability. So we looked at particularly adoption in organizational terms. So interviewing the people of the innovation, which is the telehealth, whereas the text-based for diabetes automated system. So when you interview the inventor, the managers who had to deliver it, patients, the doctor, the diabetes nurse, so you get a feel of what it meant to them at various stages of understanding it, talking about it, delivering it, afterwards, what was the benefit. And so that's already in literature. So that can be searched. The people who, you know, the adoption of technology and scalability, that's in literature. I've got something we presented in Sydney, actually, in 2019, just before the pandemic struck. we got to Sydney. I have to say though that what Mike says is really, it's really poor point. But what strikes me is what Claire was saying. This is going to be quite good, actually, I think, because what I agree. As we're coming out of, obviously the COVID is increasing, but the vaccines now have increased. You're right. There's now this transition where we are now, after that last paper, we're now going to. We're the same. We're moving more to face, but only because last year they made sure all the risk, you're allowed to do it now. They didn't have to go through all the hoops, but now as you come through, they're having to say, well, actually, we're feeling a bit jittery about this now because we allowed it in a pandemic. Post-pandemic, they're a bit scared about, well, can we carry on doing this, and what's the risk? And it's a multitude of risks. It's a multitude of behaviors, because the patient feels now they've got a barrier to seeing a doctor. How do you get over that? The doctor feels that the risk of, because seeing a person automatically removes all the legal risks, all the technical, you just see them. And also workload, you're right, Kleber. The cost, you know, if you get paid to see someone and you're seeing twice or three times that amount, you're working hard, or you think it's not hard because you're not seeing them, but you are. And it's really wearing. So thinking, well, why do we have to do this if we're getting paid exactly the same? And the payment is a big issue, I think. In some it is, because, you know, especially in fee-paying area, you know, items of service payments, we've got public service. There's a problem. So I think one interesting paper now would be following on from the one we did in January, which is, we're coming out of it now. What do we do with these guidelines? They are in place now. They were put in very quickly. How can we maximize this thing? And it fits in with, I think, what Mars was saying and what you just said, Clever. Am I right in saying that? Does that resonate with what you said? Yeah, I think so. And that would be really interesting, because we're coming in following on from a paper we've done, which has said what's happened with COVID. And now we've got to say, well, it's here now, we're coming out of it. But there's a danger and a risk, as you said, Clever, that we're going to end up face-to-face, which the only reason why we're going to face-to-face is because the technology has to move quite quickly to fill the gaps which have been created by moving from face-to-face, because it's so easy just to go back. It's just the easiest thing, just to go back and forget about, you know, it would always be this IT, but it might be just really tiny at the end of the day. So we've got to sell a message, but that's only, and so this would be quite interesting, what countries are doing to realize the benefits of IT rather than being scared of the IT. How can patients feel, or consumers feel, this is good, rather than they're not letting me see the doctor, I'm not getting to the hospital, I'm not seeing my, but, you know, I feel hard done by that. It is a thing. The patient-doctor or the patient-person relationship is more important than we think. And again, there has been a lot of papers on this as well, because I've been looking at, the BMJ's got quite a few things on this kind of thing we're talking about, but we can bring that together.
Yep. Wow, we had a rich set of ideas and things that we have discussed today, particularly the ones that you've been talking about, all the ones about what happens in a post-COVID era. What is the role of telehealth, telemedicine in post-COVID era, particularly that now that we are coming out of it? Are we coming out of it? Possibly. But what happens, you know, certainly when we've seen that what was normalized in terms of lockdowns and people being, you know, not in a face-to-face contact, a very different situation today as opposed to what it was a year ago. And what does it mean? I mean, where does telehealth, telemedicine, and telecare of delivery services, what does it mean now in terms of guidelines and practice, isn't it?
Thinking about it, more specific would be, you're right, the COVID isn't going down, but it's more in a post-COVID vaccination era.
Post-COVID vaccination.
Is that, isn't it? I'm just thinking about it now, because COVID's going to be like massive still. It's going to be really big. But it's the vaccination. So it's a post-high, and it's country be different. So we're talking about what specifically countries, as we increase vaccination rates and immunity, what does that mean in terms of telehealth? So that would be more specific if you're going to say.
Oh, that's a fascinating piece of work. If you could do that, to say that, okay, what happens when we have a game changer technology suddenly coming out, which is not entirely dependent on teletechnologies, but we were all used to the telehealth and telecare and teletechnologies, and what does it mean now? Yeah, in terms of now the countries are opening up. Yeah. So where does that place us? Yeah, because quite clearly, I mean, there was a defined place of telemedicine a year ago. And we kind of knew what we were doing. Now that we are going, we have a choice, isn't it? A choice that was not really that apparent 2 years ago. Is that how you see that?
I think the added factor is these people who held back with their illnesses, they are coming now. I mean, they're coming back. They're not so scared. They've had enough of this waiting. They want their usual. They're used to having their needs. We are this thing about this backlog. We're going to see I think up to 13 million backlog. In other countries will have. We're going to see it. All these people in all these countries, we're not coming, or we're told the services shut down while we protect ourselves. The vaccine has changed that. So these people are added on to the ones who are going to come now. So you can imagine, they don't go away.
No,
they don't go. So this is why the telehealth is the technology is needed, the digital. Because if you just carry on doing face-to-face with all these people, that backlog is going to stay. Yes. And so this thing about consumer, that if you can get a lot of those dealt with safely, but it's a balance between what's the sensible way forward, then they can maybe if you've got abdominal pain, who do you see? It's the same thing. Do you see everybody? Or do you maybe risk assess? And we're doing things as doctors that we never used to have to do to this level.
Yes.
So you may be doing remote, but not to these numbers. This is it's all right for a while we've got a pandemic. But after a while, you think, well, it's our practice which is going to be scrutinized.
Exactly, and that's something that needs to be evaluated and probably. But I'm not sure if the guidelines kind of capture these realities. Do they or do they not?
Well, I think we need solution. I think this data is going to be available. I think it's going to be a lot of scrutiny. But I think what we got is what do we want? What do we need? With knowing to these facts, we don't necessarily need to tell people the facts, but they come into the conversation, into the argument about why. So I think really it still comes back to the informatics. What are we going to? How are we going to target? How we're going to this conversation is quite good because you're talking about post-vaccine COVID vaccination era.
Yes.
You're talking about restoration of services. Are we moving to? We've got a high level of non-face-to-face. Are we going to be moving more to face-to-face? So this is where the discussion becomes very most interesting. So how mature are some countries or organisations within those countries? People within those countries? Within those countries? I mean, it's going to be fascinating to do another paper just to see where we are now, because I think it'll be different to last year.
Where we are now, indeed. And that's, And there's so many, yeah. Yes, where we are now, where we are heading, what has it been?
I think politically now, all countries, they're trying to open up, obviously for economic reasons now.
Yeah.
So we are all going to see changes in policy, changes in scientific advice, you know, all the stuff is going to be now coming. So it's going to be a different era. By the time, you know, each week now, it's moving to opening. We're going to be opening probably 19th of July, about a week or so. Other countries, we're doing similar things. People were using vaccine powder. But the thing is, people will be starting to enter the healthcare service again for their problems, psychological things, COVID. Sorry.
I want to add something. I think how change is the relationship between the professional, the health professional, and the patient. Mm-hmm. And what this kind of change impact in the telehealth post-COVID, vaccine COVID? I think this is a good question, because we are talking here about the relationship with the professional and the patient. How it's changed if you don't have face-to-face, and but we have the camera. The camera for the patient substitute the face-to-face, maybe or not. I don't know. I think the key of the thing, the relationship. What's the change in the relationship with the professional and the patient, and how is the impact of this in the health system? I didn't talk. I think we can talk more, not on the telehealth, but in the health system. Now you have the hybrid. Kleber, can you help me? Híbrido in English?
Acho que hybrid, like face-to-face and remote consultation
remote
on
consultation.
the same agenda.
Yes, yeah. The same. The both are only one thing for psychologists. I know that the consultation with psychologists is very good with the telehealth. But one thing that I'm in doubt is how can we answer this question with the interview. I think interview is something that we can use in this working group. We can ask for opinion of all of the people in this group, and I think, I don't know how can we do it, but which one of the researchers or members of this group can do a little research in his country, interviewing the patient or all other professionals. It's a big research.
Yes, it
very
is.
Work, but I think it's something that we can do because we have a member of all of the world, so we can do an effort in this way.
Yes, we certainly can, and we should do that, because we did something very similar as to what, Marcia, you were asking in New Zealand. It's just a very small one. We have got 2 islands, a North and a South Island. We just had funding to conduct a study of all the clinicians and how they were using telehealth to meet with the patients and what they were thinking. And we found something very interesting. For example, we found that while the clinicians, the medical doctors and the surgeons, they were happy, yeah? Some nurses were happy, but people who were like midwives, they did not like the use of this medium at all, because they felt that they were missing out on the physical touching and interaction bit with the patients. And then there were people who were rapidly and quickly were to adapt to the technology. They were happy with the system, but not necessarily the ones that needed more hand-holding and some more kind of guidance and, you know, technology kind of solutions. People who did not have, who were in the remote areas, who did not really have the technical support, they were not necessarily happy using the telehealth as a tool. And that kind of borne out in other areas too, that, you know, some patients who did not really have the devices to play with, they felt that they were left out. So it's not really simple, because it's one side of the game that we look at it, the other people who are there. Exactly, you know, things that we're talking about, your consumer ones.
I think the COVID has been disruptive.
Yep.
The technology has been disruptive. But I think what I was also saying, I think things might, you know, are we going to be looking at things in the same way? Will the relationship be the same between healthcare professionals and patients, or will it be a different reset? That people want access as one of the big ones. They want a personalization and continuity, but they want access, and that makes them angry if they don't get what they want. It's just the way things are now. So if you get access, there's a price to be paid, because you then have to decide, I'm going to not wait for the person I want to see. I'll see whoever's available, but I want a good service when I do see somebody. So this disruption that we've had, it creates a new reality, and people aren't looking at that, or maybe not. We don't know how it's going to end up, but you're getting a lot of now, the workforce is changing, because doctors, you're getting allied professionals, nurses. So that's crept in because, you know, you get a phone call by somebody,
Yes.
you know, you're not guaranteed. I'm sure it's happening everywhere because of for lots of reasons. So there is going to be a change, I think. And what would be interesting is, this is more behavioral psychology. There will be evidence already on this kind of, as you said, this, you know, what it means for people, because that's behavioral scientists. They'll all be looking at this. I mean, bound to be. It's COVID, isn't it? It's research like galore going on in the EU everywhere. So I think we'll find that out. But the thing is, how we translate from the IMIA group will be important, because what does that mean?
Yeah, for us.
So personally, I'm keeping never mind how this will end up. But you're right, what Claire was saying, we could just end up the safety thing. Oh, we can't be bothered. It's just too much like hard work. We'll just go back to face. It is easier, but can you manage? The demand was already going on before COVID.
Yes.
Okay, it's just going to go like that. Expectations are high for getting what you want.
Yeah. No, it's fantastic. I think we are 1 hour into our discussions. Of course, we will continue this dialogue, and we will continue this going into the next weeks, and so on and so forth. So what I will do now is, of course, we'll have the recording and things like that I'll put up, and I'll summarize the excellent discussion that we had today. I mean, I love you all, and put it up on our group. And we'll see if we can share some of the resources. Maybe Marcia, going forward, if you can share some of your thoughts on the process mining, particularly in telehealth, and, you know, Vijay, your thoughts about the artificial intelligence, and if you can contribute each to the discussions.
I caught the last few minutes of the interesting discussion.
Yes, go ahead.
I'm sorry about that. I caught just the last few minutes. I was actually driving from another town nearby.
Wow.
And I expected to be here at 3, but I was delayed on the highway. So I'm sorry about that. Oi, Kleber. Oi, Marcia. It's bom. Oh, nice to see both of you. Kleber, há muito anos e não se vejo.
É verdade. Abraço.
So good. Yeah, but it sounds like you had a really, how many people were here?
Oh, I think the 5 of us, and then we had Alan Taylor join us for a brief while. Okay. I think he may have had connection issues. So yeah, it's a small group, but we had a very rich set of discussions today.
I can see that.
Yeah, no, we can. Yeah, we had a lot.
Good.
Yeah.
So again, Disculpe Marsha, Disculpe Kleber, sorry Vijay, sorry Aaron.
That's right. That's
expected to be here, but
no, that's all right. That's
I got
fine.
Delayed on the highway. So,
no, that's not a problem at all. I mean, it's I mean, we're here. We were discussing. Anybody can hop on. That's fine. So we'll continue. We'll keep this conversation continuing. both on our forum, and I'm going to, you know, definitely once I get the recording, I'll post it onto the, as I've been posting it. And please feel free to add to it, and we'll set up another meeting next week. Sriram, if you want to coordinate that, that'd be great.
Sure. Okay.
Yeah. So you can be the discussion later next week. However, I mean, it can be open to anyone.
Okay.
So on that note,
good.
Yeah, go ahead. Yeah.
I just had a question. Kleber, aonde é essa? Recife?
Oh, yes, okay. Recife, yes.
Okay. Fale oi para Magdala.
Okay, I'll do.
Right.
Okay, good.
Okay, all righty.
Good. Thank you. Thanks.
All righty. Thank you, and see you next week. See you. Bye-bye.
Bye.
Bye.
Bye.